Okay, welcome everyone to Journal Club for May 2023. I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are very grateful to have the opportunity to work on this land. We are in for a real treat this morning, fresh off being awarded the Dr. Sharon Strauss Resident Research Award. Dr. Carolyn Tan, PGY5, incoming lead resident, will impress you with a review of a cluster RCT of an antibiotic stewardship program for UTI. Carolyn, please feel free to share your slides and start. We can see your slides well.
Perfect. You knew what I was going to ask. Okay.
Yes, and we can hear you as well. Yeah.
So today I'll be discussing a pragmatic cluster RCT, the IMPRES-U study, on the effect of a multifaceted antibiotic stewardship intervention to improve prescribing for suspected UTIs in frail older adults. I have no conflicts of interest. Our objectives for today are to review recommendations for UTI management in frail older adults, to discuss the participatory action research approach, to critically appraise the study, and to review unique aspects of appraising cluster RCTs. Older adults living in LTC have a high prevalence of asymptomatic bacteria and nonspecific symptoms. This puts them at high risk of inappropriate antibiotic prescribing for UTIs, with up to 75% of prescriptions being unnecessary. This also makes UTIs the most common reason for antibiotic prescription in LTC. The impact of antimicrobial stewardship interventions in hospitals is well established. However, evidence supporting their use is scarce in other settings, such as LTC. Although both hospitals and LTC share similar antimicrobial stewardship goals, the structure and process differ considerably. LTC often lacks the resources to emulate the same interventions as have succeeded in acute care hospitals. And furthermore, there is greater multimorbidity and dementia along with behavioral symptoms, adding complexity to care decisions. So the question is, what are the best practice recommendations that we should be following, and how do we implement them in long-term care? In 2019, the IDSA published clinical practice guidelines for the management of asymptomatic bacteria. For older adults who have functional and/or cognitive impairment, who have bacteria and delirium, but do not have local GU symptoms or other systemic signs of infection, they recommend assessment for other causes and observation instead of antimicrobial treatment. And they make the same recommendations for older adults with bacteria and a fall. In 2017, the Public Health Agency of Canada partnered with Choosing Wisely to develop a campaign titled Using Antibiotics Wisely. They identified several key practice changes to reduce unnecessary antibiotic use for asymptomatic bacteria in long-term care. These include not performing a urinalysis to diagnose a UTI, given poor accuracy in older adults. For changes in behavior, they recommend against sending a urine culture unless the change is accompanied by minimum criteria for a UTI, which are outlined in the following recommendation. In a person without a catheter, the minimum criteria include acute dysuria or 2 or more of the symptoms listed here. In someone with a catheter, the criteria include any one of the following after alternate explanations have been excluded. Lastly, if a urine culture was already sent and comes back positive, they recommend that prescribers only treat if the reason for sending the culture persists, and then the criteria are still present. Although we have these recommendations, evidence suggests that nurses and physicians often deviate from the guidelines and consider nonspecific signs and symptoms like lack of appetite, along with non-symptom information like whether a patient or family requests an antibiotic. Translating these guidelines into practice requires effective implementation. Thus far, multiple studies have evaluated interventions aimed at implementing these stewardship guidelines in older adult care settings. They have shown some promising effects on reducing antibiotic use, but nearly all of them have a high risk of bias, use a non-randomized design, and are limited to a single country. Furthermore, few look at UTI specifically, despite this being the most common reason for antibiotic prescription in LTC. So this is where our study for today comes in. IMPRES-U is a pragmatic cluster RCT in 4 European countries that was published in the BMJ in February 2023. The objective of the study was to evaluate whether antibiotic prescribing for suspected UTIs in frail older adults can be reduced through a multifaceted antibiotic stewardship intervention. They conducted a pragmatic parallel cluster randomized RCT. Clusters consisted of 1 or more general practices and older adult care organizations in Poland, the Netherlands, Norway, and Sweden. Each cluster provided care for at least 20 older adults. Medical care was provided by general practitioners, except in Norway, where nursing homes employ physicians who may have a background in geriatrics. They included participants who were 70 or older and had, as they phrased it, physical or mental disabilities or both, and dependency in ADLs. Participants were excluded if they were on prophylactic antibiotics, receiving hospice care, estimated to have a very limited life expectancy, or ended up participating for less than 2 months. Participation ended when they died, moved away from the cluster, or newly met one of the exclusion criteria. Physicians and nurses received a multifaceted antibiotic stewardship intervention consisting of a decision tool for appropriate antibiotic use, supported by a toolbox with educational materials for physicians and nurses, as well as patients and caregivers. The intervention was designed based on the results of their earlier qualitative study, which involved interviews with physicians, nurses, patients, and caregivers on factors influencing prescribing decisions in each country. The control group received care as usual. The decision tool for appropriate antibiotic prescribing was developed by an international team of 16 experts with results published in an earlier study from 2018. They used a Delphi method with an international panel of physicians, including ID specialists, geriatricians, and family physicians. Going on a little bit of a tangent, the Delphi method is a process used to arrive at a group opinion, anonymously surveying a panel of experts. Experts respond to several rounds of questionnaires, and after each round, responses are aggregated and shared with the group. So this enables each participant to adjust their answers in subsequent rounds, eventually leading to what is hopefully the most correct response through consensus. In rounds 1 and 2, experts were asked to evaluate 38 signs and symptoms for the likelihood that they are caused by UTI. In rounds 3 and 4, combinations of signs and symptoms were presented, and experts were asked whether they would prescribe antibiotics empirically for each scenario. The result of the Delphi panel was a decision tool for empiric treatment of suspected UTIs in frail older adults, with separate algorithms for those with and without a catheter. For the sake of time, we'll just go over the latter. If a clinician suspects a UTI, they should first consider if there are 1 or more new local symptoms. If yes, and they have any of fever, rigors, delirium, or CVA or suprapubic pain, then antibiotics should be prescribed. Or if they have 2 or more local symptoms or 1 very bothersome symptom without other cause, then antibiotics should also be prescribed. If none of the above are met, then antibiotics should not be prescribed for a UTI. If they do not have any local symptoms, but do have new CVA tenderness and any of fever, rigors, or delirium without another infectious focus, then antibiotics should be prescribed. If they do not meet criteria from either of the above pathways, researchers also made explicit which symptoms should not prompt antibiotics regardless of your analysis results. This is because without local symptoms or CVA tenderness, these symptoms are unlikely to be due to UTI. So I have a couple concerns with this algorithm. They include mental status change, but without clinical suspicion of delirium as a symptom that does not warrant treatment. So that raises the question of where older adults with delirium but no local symptoms fall in this algorithm, which is an important area to address. As a reminder, the IDSA recommends that delirium without local symptoms should not warrant therapy unless there are systemic signs of infection like fever or hemodynamic instability. Choosing Wisely makes a similar recommendation, but however, as long as the patient is stable, fever alone is insufficient as there should be at least 1 local symptom. My second concern is around the recommendations or lack thereof when it comes to testing. If a urinalysis hasn't already been sent off, should clinicians order one? And the word consider for urine cultures, I find to not be very helpful. Should clinicians stop antibiotics if the culture is negative? Perhaps some of these questions were addressed in their education sessions, but they would have been important to include in this algorithm as well. To implement their intervention, they use an approach called participatory action research. And as one last tangent, before we get back to the study, I do want to spend some time describing PAR, as it was a methodology that I was not familiar with until reading this paper. In PAR, stakeholders go through a cyclical process of reflection on the local situation, development and planning of interventions, and implementation, followed by returning to observation and reflection. Similar to PDSA cycles in QI, it involves a cyclical approach with repeated cycles of incremental improvement. In implementation research, PAR can be integrated with RCTs. This methodology helps combine the rigor of RCTs with the local sensibility brought by PAR. ImprezU was the first study that I was able to find to use PAR in an antimicrobial stewardship, and one of the very few to combine PAR with a cluster RCT. Before we get back to the study, I did want to summarize some similarities and differences with QI. Surprisingly, I was only able to find one study from 2009 that briefly outlined how they were different. Both PAR and QI aim to address the gap between theory and practice. They both account for contextual, cultural, and behavioral factors and address local barriers and facilitators. They involve frontline workers, and they also use a cyclical approach. PAR views frontline workers as the research leads, while the actual researchers are viewed more as a catalyst for this process. And historically, QI looked more at the system, while PAR focused more on the relationship between individuals in the system. However, to me, it seems like the overlap between the two is growing over time with the increasing incorporation of human factors and experience-based co-design in QI. But if anyone in the audience has any experience with PAR or would like to shed more light on this methodology and how it differs from QI, it would be great if you could share during the Q&A. So getting back to our study, as part of PAR, in each cluster, one or more educational sessions were held by researchers with physicians and nurses. They started their 4-month intervention period in February 2020, but were interrupted by the pandemic. They resumed in September and held a refresher for clusters who received their session before the pause, with most sessions now taking place online. They later held an evaluation session to reflect on the implementation process and plan additional actions. The primary outcome was the number of antibiotic prescriptions for suspected UTIs per person year. The clinical suspicion of a UTI was not defined, but rather left up to the physician. And prescriptions were registered on the day of a suspected UTI or during 21 days of follow-up to include prescriptions after a wait-and-see policy. Secondary outcomes included the number of suspected UTIs, number of inappropriate antibiotic prescriptions for suspected UTIs, all-cause mortality, and a few secondary outcomes within 21 days of each suspected UTI, including complications like delirium, pyelo, sepsis, renal failure, all-cause hospital referrals, admissions, and mortality. Data collection took place during a 5-month baseline and 7-month follow-up period. And data was collected through case report forms completed by the physician, nurse, or researcher. Each UTI was prospectively registered, and after 7 and 21 days, follow-up forms were filled in to assess complications and mortality. An independent data manager performed block randomization to assign clusters to intervention or usual care, stratified by country and cluster size. And due to the nature of the intervention, blinding was not possible, but study aims were not explicitly stated to the control clusters. For the primary outcome, they use a generalized linear mixed model. Compared to a linear model, this allows observations to be correlated and to be not normally distributed. In a second model, they adjusted for a variety of pre-specified prognostic factors. For the secondary outcome of all-cause mortality, they also adjusted for cardiovascular disease and immunosuppression, and all analyses were intention to treat. They also performed a planned subgroup analysis to assess the primary outcome based on country, age, sex, and the presence of dementia, urinary incontinence, or an indwelling catheter. They used multiple imputation to assess the impact of missing values on variables selected as potential confounders. And lastly, to evaluate whether the pandemic affected the intervention and usual care clusters differently, they assessed the presence of COVID-19 outbreaks in participating clusters. 106 clusters were assessed for eligibility, with 56 declining to participate and 11 not meeting criteria as they did not include enough older adults. So this left us with 39 clusters comprising 2,641 older adults. 19 clusters were sent to the intervention and 20 to usual care. About 700 older adults were excluded in each group for a variety of reasons, such as not being eligible, declining to participate, not responding, and logistic reasons such as staff changes. One Polish cluster with 42 older adults was lost to follow-up due to closure of the nursing home. And in each group, a further 30 or so participants were excluded because they died, moved away, or became ineligible for other reasons like starting prophylactic antibiotics. This left 502 older adults in 19 clusters in the intervention group and 539 older adults in 19 clusters in the usual care group. The majority of participants were women, and the mean age was 86.3. 77.6% lived in nursing homes, and 19% lived in residential care homes, which provide a varying level of ADL care, often by nurse assistants with less nursing education than in nursing homes. 7% of participants in the intervention group were living at home and receiving home care, while no participants in the usual care group resided at home. Many participants had comorbidities, most frequently cardiovascular disease. Only 38% of participants in the intervention group had dementia, compared to 51% in the usual care group. 12.5% had recurrent UTIs, 7.5% had an indwelling catheter, and 57.8% had baseline urinary incontinence. The mean CATS ADL score was 2.8, which corresponds to moderate to severe functional impairment. And overall, there was some variation between countries. For example, the Polish participants were younger with a mean age of 83, and the participant with dementia was highest in Norway at 68% and lowest in Sweden at 24%. Of the 1,041 participants, 242 got antibiotics for a suspected UTI with an average of 1.4 prescriptions during the entire study period. The number of antibiotic prescriptions for suspected UTIs went from 0.5 per person year to 0.27 in the intervention group, compared to 0.44 per person year to 0.58 in the usual care group. The unadjusted and adjusted rate ratios were similar at 0.41 and 0.42 respectively, favoring the intervention group. And a similar rate ratio of 0.39 resulted from multiple imputation analysis. This forest plot illustrates the result of their subgroup analysis. The intervention was stronger in older adults with dementia and in older adults without urinary incontinence. The intervention effect was similar in all countries except for Sweden, which appears as the most salient finding in this figure. Antibiotic prescribing rates were relatively low at baseline in both groups in Sweden and declined further in the usual care group. The authors speculated that this was due to a Swedish strategic program against antibiotic resistance called STRAMA, which has been implemented for many years. In both adjusted and unadjusted models, the intervention group had lower rates of antibiotic prescriptions during office hours on the day of the suspected UTI and a lower incidence of suspected UTIs. There was no difference in all-cause mortality. The authors had also reported that the intervention group had lower rates of inappropriate antibiotic prescriptions, even though, as we can see here, the confidence interval crosses 1 in both models. So I'm interested to hear how our experts in the audience feel about this. But what I've heard is that there has been a shift towards looking at confidence intervals with some skepticism, since crossing 1 could be due to a small sample size or a small number of events, leading to imprecision. So I wonder if this is why the authors came to this conclusion. But I do think that this could have been phrased differently in their results section, with something along the lines of there appearing to be a 53% reduction, but we cannot be certain due to wide confidence intervals. Due to low numbers, only descriptive statistics were provided for the other secondary outcomes, but I do want to draw your attention to how these were reported. So most of the secondary outcomes are based on the number of adverse events within 21 days of suspected UTI. But there were substantially fewer documented UTIs in the intervention group. Because there were fewer events, there was fewer opportunities for the secondary outcomes to occur in the intervention group. Therefore, we do need to take these numbers, which at first glance look quite favorable for the intervention group, with a grain of salt, since these outcomes would not have captured any consequences of any UTIs that were entirely missed in the intervention group. The last thing that I'll mention about the secondary outcomes is that I found the wording in the reporting to be inconsistent and slightly confusing. In the abstract, the author stated that there was no difference between the groups. However, in the main text, they said that the secondary outcomes were lower in the intervention group, which is a conclusion that I don't think can be drawn based on their numbers here. In terms of the impact of the pandemic, in the follow-up period, 15 clusters had at least one COVID outbreak. The differences between countries were quite large. 7 out of 8 clusters in Poland had outbreaks, while none in Norway had outbreaks. In Sweden, the outbreaks occurred in 3 intervention clusters only, and I wonder whether this contributed to the lack of benefits in the intervention group in Sweden, as we saw in the forest plot. So the authors concluded that implementation of a multifaceted antibiotic stewardship intervention resulted in a substantial clinically relevant reduction in antibiotic prescription rates for suspected UTIs in frail older adults. They further concluded that the reduction in antibiotic use appeared to be safe, as adverse outcomes and all-cause mortality did not differ between groups. How confident can we be in this conclusion? Let's appraise this article. So for this article, I used the revised Cochrane risk of bias tool for cluster randomized trials. We'll first look at whether we think the results of the trial are valid. Our first domain is bias arising from the randomization process. Was the allocation sequence random? Yes, block randomization was completed with SAS, stratified by country and cluster size, small, medium, or large. Was the allocation sequence concealed? Probably yes. It wasn't stated clearly as concealed, but it was handled by an independent data manager. So overall, I gave the study a low risk of bias in this domain. The next domain is bias arising from identification or recruitment of participants. And this is a key difference between assessing risk of bias in cluster RCTs compared to individual RCTs. In individually randomized trials, consent is obtained and then randomization occurs. In cluster RCTs, the clusters are recruited and then at some point they are randomized. Participants don't get a chance to consent to randomization since that consent is done at a cluster level. They can, however, consent to data collection and participation. But the issue is if activities are done in this order with intervention assignments known prior to the individual participant recruitment, then this can lead to identification or recruitment bias. In other words, bias stemming from the knowledge of the intervention assigned to a cluster, affecting recruitment and identification of participants. So let's remind ourselves of when participant recruitment happened in our study. So first, clusters were assessed for eligibility and recruited. They were then randomized to intervention or usual care, and then the participants were identified and recruited. So coming back to our risk of bias tool, were all the individuals identified and recruited before randomization of clusters? No, this occurred after the clusters were already randomized. Is it likely that selection of participants was affected by knowledge of the intervention assigned to the cluster? So because researchers and nurses who were not blinded to the intervention assignments obtained consent, resulting this identified in the potential for bias, so I gave them a probably yes. Were there baseline imbalances that suggest differential identification or recruitment of individual participants between groups? So let's first answer this question at a cluster level. All 3 clusters of community dwellers happened to be randomized to the intervention group. This was likely due to chance, since randomization of clusters had been done by an independent data manager. It is more common to see these chance imbalances in cluster RCTs due to a relatively small number of clusters. At an individual level, we did see notably more participants with dementia in the usual care group. Could this have been due to more enthusiastic identification and recruitment of participants without dementia in the intervention group? There may also have been some differences between clusters, such as the 3 clusters with community dwellers having less dementia. However, even if all these community dwellers didn't have dementia, it still wouldn't account for even half of the difference between groups in dementia prevalence. So I gave this one a yes. And overall for domain 1B, I gave the study a high risk. Domain 2 is bias due to deviation from the intended intervention. Were participants aware they were in a trial? Yes, so the author stated that the aims of the study were not explicitly stated to the control clusters. Were participants aware of their assigned intervention during the trial? Yes. Due to the nature of the intervention, blinding of clinicians and researchers delivering the intervention was not possible. Were important co-interventions balanced across intervention groups? Yes. Time spent with the researchers, including the various sessions, as well as regular phone check-ins, had initially stood out to me as an imbalance. However, because these are parts of PAR, they're still considered part of the intervention. However, because this is an RCT of the stewardship program implemented using the PAR approach instead of PAR itself, I think the investigators could have found ways to make researcher engagement with participants more equal between groups. However, because all the aforementioned interventions were part of the protocol, I still gave them a yes, but with limitations. Were there failures in implementing the intervention that could have affected the outcome? Possibly. However, these were mostly pandemic related instead of intrinsic to the study design. Due to the pandemic, there was a 6-month pause. They added some refresher sessions and they switched to the virtual format. There were also outbreaks in some clusters, which may have impacted implementation. Was an appropriate analysis used to estimate the effect of assignment to the intervention? Yes, all clusters and individuals were analyzed according to the groups to which they were assigned. So overall, taking the above findings into consideration, I considered there to be some concerns in this domain. Domain 3 is bias due to missing data. Were data available for all clusters that recruited participants? No. In the usual care group, one Polish cluster with 42 older adults withdrew from the study during the baseline period because the nursing home closed and the data could not be retrieved. Were data available for all or nearly all participants within clusters? Yes, even with the missing cluster, the loss to follow-up was less than 10%. However, it would have been nice to see any available data for participants who were lost to follow-up, as well as information about those who declined to participate. And is there evidence that the result was not biased by missing data? Yes, they performed multiple imputation to assess the impact of missing values and obtained similar results. So overall, I gave them a low risk for this domain. Domain 4 is bias in measurement of the outcome. Was the method of measuring the outcome inappropriate? Possibly yes. UTIs were prospectively registered, which may have prompted awareness of prescribing behavior, in other words, the Hawthorne effect, and consequently lowered prescription rates in the baseline period in both groups. And the overall increase in the follow-up period could reflect a regression to the mean in clusters with usual care. Could measurement or ascertainment of the outcome have differed between intervention groups? I gave them a yes, because physicians, nurses, and researchers who were all aware of the intervention allocation were responsible for recording most of the outcome measures, which can lead to ascertainment bias. So for these reasons, I gave them a high risk for domain 4. Lastly, domain 5 is bias in the selection of the reported result. Were the data analyzed in accordance with a pre-specified analysis plan that was finalized before unblinded outcome data were available for analysis? No, they do have a published protocol. However, this was submitted near the end of the follow-up period. And because researchers were involved in data collection, they likely would have had access to unblinded data during this time. So that leads to some concerns for this domain. And overall, looking across our 6 domains, there are some concerns about the validity of the results, primarily stemming from awareness of the investigators and clinicians of their assigned intervention and the various roles that the investigators played, including recruitment, education, and data collection, despite having this awareness. Moving on to our next section of the appraisal, how large was the treatment effect? In the adjusted model, participants in the usual care group were greater than 2 times more likely to receive an antibiotic prescription for suspected UTIs compared to those in the intervention group, with a rate ratio of 0.42. This is a larger effect size than most of the studies included in a 2019 meta-analysis, but was the exact same effect size as what was found in a Danish cluster RCT that was conducted just prior to the pandemic and published while the current study was ongoing. The authors proposed that shared factors for success may have been the active participation of nursing staff and incorporation of reflection to address behavioral aspects of decision-making. The results are also similar to the only Canadian cluster RCT on this topic, which was published back in 2005. How precise was the estimate of the treatment effect? The 95% confidence interval was quite narrow at 0.26 to 0.68, indicating that the estimate is quite precise. However, we must remember that this does not necessarily reflect accuracy, which could be affected by some of the limitations that we mentioned earlier. Lastly, will the result help me in caring for my patients? The older adults included in this trial were frail, primarily living in a nursing home with a mean age of 86, and 44% were living with dementia, supporting applicability to our patient population. While the decision tool seems easy to use and feasible to implement on an individual clinician basis, I do think it may be more challenging to implement the tool and other aspects of their intervention more broadly, since their methodology is not easily replicated without certain expertise and resources. And voluntary participation also likely impacts generalizability of the results to nursing homes with less interest in antibiotic stewardship. So with this study, investigators addressed an area of great clinical interest in an understudied population of frail older adults living primarily in nursing homes. They had a large sample size with pragmatic design that involved multiple countries and had a control group. They had a high level of data completeness and included truly frail older adults with much greater representation of those who have dementia than in past studies. They also used a combination of methodologies to deal with the complexities of this topic and address previously identified barriers to uptake. Furthermore, they did a lot of groundwork prior to this RCT, including the development of a decision tool developed by a Delphi panel, as well as an in-depth evaluation of the factors affecting prescribing decisions in their study population, which helped them tailor their intervention. Lastly, although it's possible that the pandemic may have limited the validity and generalizability of the results, I do think it's a positive finding that the intervention was effective despite difficult circumstances for implementation. In terms of cautions, as mentioned while we were going through the methods, one of the shortcomings for the study is the lack of clarity around urinalysis and urine cultures in their algorithm, as well as the fact that it did not address what to do when participants have delirium but no focal symptoms. There are also a few limitations when looking at their secondary outcomes, which we previously discussed. We also have the cautions that were raised during our critical appraisal, including the possibility of selection bias with greater involvement of care organizations that have an interest in antimicrobial stewardship, identification or recruitment bias from knowledge of the intervention assigned to each cluster prior to participant recruitment, a greater percentage of participants with dementia in the usual care group, a lack of blinding and possibly of ascertainment bias, given that the unblinded investigators were involved in data collection, a Hawthorne effect of impacting behavior of clinicians, and the potential impacts of the pandemic. Some additional cautions that were not previously mentioned include the fact that they did not collect any information on antibiotic prescriptions for other indications. And theoretically, the decrease in antibiotic use for suspected UTIs could have been accompanied by an increase in antibiotic use for other indications. They also did not evaluate the impact on antibiotic selection and duration, which are also very important aspects of stewardship. And while only a small number started prophylactic antibiotics, 5 in the intervention group and 1 in the usual care group, the reasons for this and any potential impacts of the intervention on these numbers would have been good to explore as well. Other outcomes of interest that would have been helpful to see include adverse drug reactions, C. diff, and antibiotic resistance rates. And as with many multifaceted interventions, it is a bit difficult to understand the value of the separate components of their intervention. There was no observed increase in the number of prescriptions in the intervention clusters during the 7-month follow-up period, but we do wonder about the long-term sustainability, especially since some intervention clusters received refreshers after the COVID-19 pause. A subgroup analysis by site of residence, whether nursing home, residential care home, or home with home care, would have been helpful given the substantial differences in staffing across these settings. However, this was likely not possible given the low numbers of participants in the latter two settings. Along these lines, even though they generalized their findings to frail older adults regardless of place of residence, we should remember that the older adults living at home with home care services were very underrepresented. And lastly, I had some difficulty visualizing the outcome of the PAR approach. And I think it would have been helpful if they included specific examples of how the algorithm or toolbox materials were adjusted in the different clusters. Though it's possible that they may include this in their process evaluation paper, which will be published separately. So in summary, a multifaceted antibiotic stewardship intervention reduced antibiotic prescribing for suspected UTIs in frail older adults who had a high prevalence of dementia and lived primarily in nursing homes. The intervention was effective across most subgroups and appeared to have a stronger effect in patients and in participants with dementia, which is particularly important given the challenges with stewardship in this population. However, the intervention appeared less effective in those with urinary incontinence, and therefore we await the development of tools that will improve the management of UTIs in this population. Even though there are several cautions to keep in mind, this study still provides some of the highest quality evidence on this topic to date. The results can be used to advocate locally for greater focus on implementing stewardship interventions for frail older adults, especially those with dementia. And the investigators also raise awareness for combination methodology and the importance of building capacity in methodologies like PAR and QI, which are well suited to these complex clinical decisions in team-based settings. Lastly, I've included the link to 9 practice change recommendations from Choosing Wisely for antibiotic use in long-term care. And on that page, they also have a patient and caregiver handout that addresses the misconceptions around UTIs, the role of antibiotics, and includes recommendations to help with UTI prevention. So Dr. Gandel stole my pun earlier, but did Impress You truly impress you? I hope that no one thought we were going to end without someone using that pun. Overall, I'm going to say it's a mix of gram negatives and positives for me. I look forward to your input, as some of you may see differently from me. So let me know in the Q&A. I won't be upset if you think I'm not right. Thanks so much for listening.
Thanks very much, Carolyn. That last nitrite was particularly great, but you certainly did impress me with a fabulous presentation, the description of the methods and the detailed critical appraisal. Thank you. That was wonderful. And we have some emojis and a hand up and a comment in the chat box. So Barry, go ahead.
Carolyn, that was absolutely fantastic. I'm so impressed. I just want to reflect on the old literature on antibiotic sort of stewardship. Every time there was a study on intensive education in hospitals, there was a dramatic decrease in the use of antibiotics, which reverted either at 6 months or a year in follow-up back to baseline. So I think I'm not in favor of antibiotic stewardship interventions. I think you need an antibiotic stewardship process that is continual. It's easier to do in hospitals, but we still have to have antibiotic stewardship at all times. So I think it's a difficult process. The sustainability is going to be difficult. And then on a personal note, I just want to say that when I started off my practice, I shared offices with an infectious disease specialist. Some of you might even know. He's now retired, who always reminded me that if somebody came into hospital with a fever and bugs in the urine, it was much more likely to be pneumonia than it was to be a urinary tract infection. So I was skeptical right from the beginning. And then the other personal note is it was great to see that the guidelines featured at the first name, Lindsay Nicole, the former chair of medicine and head of infectious diseases in Manitoba, who one of the few Canadians who's ever had a lead article in the New England Journal on a geriatric topic. There are a few of those anyways, and to have a Canadian do it. And when she came to visit us and speak about urinary tract infections many years ago, She was just unbelievable, an incredible human being as well as an incredible ID person and researcher. Thank you.
Thanks so much, Dr. Goldlist. I can always count on many additional teaching points from you after our presentation.
Yes, thank you, Barry. Thanks for coming back to Journal Club. I don't know how you resolved your conflict, but we're so grateful for it. Go ahead, Carol.
That was delightful. Thank you so much, Carolyn. On the ground, as the geriatric psychiatrist going into long-term care, I can tell you there has been a shift. It started pre-COVID with a lot of interventions with respect to stewardship in general, but there's definitely a shift on the ground. Earlier in my practice, everybody who had any behavior was getting a dipstick in their urine, and nurses were just doing them. And there was a lot of prescriptions, but on the ground in the few homes I go into, there's been a definite change, and there's a lot of hesitation before doing a dipstick or even prescribing antibiotics. So I think there has been a subtle but important shift, but I would agree with Barry that it's an ongoing challenge.
Great, thank you. Go ahead, Gary has his hand up.
Carolyn, that was a tour de force presentation. I don't know how else to describe it. And those who know me know that I loved the humor at the end. So thank you for that as well. You put the big smile on my face. You know, as someone who does research and knows how difficult it is to do a study like this, I have tremendous respect for the research group that did it. But, you know, you pointed out many things that give pause, and it's always difficult when you do a thorough critical appraisal to then make some type of gestalt decision about to what extent do the limitations that you identify negate or diminish the confidence you have in the result. And because of the exceptional job you did, this was no exception to that rule. I guess just to point out a few things and ask your thoughts, and I may have missed it. You know, a lot of the guidelines around prescribing for urinary tract infection revolve around symptoms. And of course, in populations with large proportions of individuals with diagnoses of dementia, in which case they are less able to voice symptoms related to urinary tract infection. And particularly in a study where there was a disproportionate number of individuals with dementia in the two intervention groups. Can you speak to me a bit about that and how that may have impacted the study?
Thanks so much, Dr. Nagley. That's a great point. And they actually didn't discuss or mention challenges in terms of symptom determination in their patients or in their participants with dementia. And I do note that the most common symptoms reported were pain with urination or suprapubic pain, but they didn't really elucidate how that determination was made or what challenges clinicians tend to encounter when trying to make that judgment. I wonder if some of that information will come to light in their process evaluation paper, where they go into further depth about implementing this algorithm and the results of their education and evaluation sessions. But certainly that would be very interested to see what they have to say about that.
Carolyn, along those lines, could you remind us which group had more individuals with dementia and how might that have impacted the result?
Yes, so there were 51% dementia prevalence in the usual care group compared to just 38% in the intervention group. So initially I thought that may make their results more favorable for the intervention group. However, they did find in their subgroup analysis that the intervention was actually had a stronger effect in individuals with dementia. So it's sort of negating my sort of instinctive response to that difference between the groups.
So it's hard to know, I guess, is the bottom line. Just to your question about confidence intervals, so I point out that generally speaking, our approach to secondary outcomes, regardless, is that they're hypothesis generating. Hence, when you have a confidence interval that crosses 1, particularly in a secondary outcome, I don't know that it has that dramatic an effect, because at the end of the day, I would suggest, and in this case, it crossed 1 by a small amount, that one would argue that there's still a significant signal in that direction. And given that the secondary outcomes hypothesis generating anyways, I don't know that that dramatically impacts how you would interpret it. It creates more challenges, of course, when that occurs with the primary outcome. And as I've told this group many times, when the study result is negative, I'm really cautious, and in terms of looking at a confidence interval and making the determination, is this a negative study that is conclusively negative or not? So in other words, if the confidence intervals are large and it may have missed a significant benefit, then I would consider that to be a non-conclusive negative trial. In the case where you have a positive result, but the result clause, you get a p-value of 0.06 and a confidence interval that slightly crosses 1, I think you have to go back to understand what are the principles of p-value and what does it really mean. It has to do with a certain percent likelihood, right, that you had a positive result by chance, and you just have to factor that in. But there's no question that causes a lot more hand-wringing in a primary outcome result, and generally speaking, the community will not accept a positive result does not meet their initial criteria that they set for a statistical significance. So I probably didn't answer your question, but those are just a few thoughts about that issue.
Thank you.
Thank you very much. There's go ahead, Carolyn, if you wanted to reply. Nope, great. There's Orisha has another humorous pun. Excellent critical appraisal and presentation, as well as identification of the gram negative for this study. With some reply. Perhaps I can ask a question. Well, you did describe a little bit of, PAR or QI methodology and the intersection or integrating with traditional randomized controlled trial design. I wonder if you ever see the statistics reported in a QI lens and traditional RCT statistics side by side. So could this have been amenable to an interrupted time series presentation of data, and would that have yielded more insights or thought other than this endpoint type analysis or traditional RCT p-value analysis? And I don't know if Gary has a comment on that, or if any publications are doing this, that process change that could be amenable to measure via QI is reported via those statistics as opposed to, traditional RCT reporting.
It was quite limited in terms of the number of papers that I found that even combined any of these methodologies, and I've yet to see a quality improvement paper that combines with the RCT methodology. But I would be very curious to see if that becomes a bit more common in the future, especially if we deal with these complex scenarios. I do think that it would yield potentially more helpful and useful results than maybe either one in isolation in certain clinical situations.
Because what Carol mentioned, that subjectively, anecdotally, the experience in clinical practice is that things are changing over time and improving over time. And so it's then easy to say that maybe it was this one time point intervention that was not sustained, or there were other system factors that were driving the change over time that would be captured in QI, but not necessarily captured in two discrete time points compared.
Exactly. And I think that would also, oh, sorry to interrupt. I think that would also be helpful for them to troubleshoot. If sustainability was found to be an issue, the quality improvement methods would be helpful in addition to the RCT methods in terms of troubleshooting and finding out why things did change over time.
Okay. Go ahead, Gary.
Yeah, I I agree with the discussion and how process and, randomized trial results, that they are both important in their own way. I mean, at the end of the day, and we know, for example, historically, results from randomized trials take like 20 years to be incorporated into clinical practice. And some of the techniques of quality improvement with mixed methods approaches and understanding, for example, what are some of the barriers to why things aren't being implemented are extremely important. There's other factors that impact that. I'm learning with the Driving Dementia Roadmap, because we're so focused on knowledge mobilization to get it out there, how labor intensive it actually is to try to make people aware in the first place, and then to what extent, even when you create awareness, that they implement it into practice. There's an enormous lift, and of course there's rooms for QI approaches to sort of assess that and encourage interventions being implemented. I was going to ask Carolyn to opine about, what are, you raise, it's an imperfect study. All studies are imperfect, perhaps raises some questions, but at the end of the day, I guess I'd ask, what are the negatives? Like, why would one not or consider implementing something like that? In other words, are there significant potential adverse effects that to doing this or not? Was the study actually adequately powered to look at things like all-cause mortality, which notoriously is difficult to assess because it usually requires thousands and thousands of people to do that? And bearing in mind that there's a certain labor intensiveness of staff, maybe training, etc., that's potentially a negative. So do you think that there are significant negatives to why we have pause, or despite some of the limitations, that there's sufficient evidence that it's worth just moving forward?
So instinctively, I would say we should be moving forward with more of these stewardship interventions and implementing these tools to help clinicians with this challenging issue. In terms of the study itself, all-cause mortality was similar between both groups. The other secondary outcomes like complications, hospital admissions, etc., those were only looked at for those who were labeled as having a suspected UTI. So the issue is, if people or if clinicians in the intervention group completely miss the UTI altogether, those outcomes are not captured in this study, which I think was a flaw in their selection of the secondary outcomes.
Yeah, I would agree that's a major flaw in that. That being said, do you think that there are major, I guess you said that you think despite these flaws that it's worth forging ahead, and I think that there's a movement, as Carol pointed out, and as you pointed out, with choosing wisely, etc., to move in this direction as well. Certainly the Apotex Baycrest nursing home has embarked on antibiotic stewardship probably for, I don't know, it's over 10 years, working with us, Sinai partnership to do that. So I think we're likely moving in that direction. And if nothing else, a study like this just gives some support to keep doing that.
Great, thank you. I hate to cut this off, but a very extraordinary presentation that led to an incredible discussion, and I'm glad we had the additional time for it. Lots of applause being offered. By way of announcement, please do complete the evaluation that was recently distributed from Helen, and we look forward to seeing you again soon. Have a great day.